Very warm welcome, our valued attendees. This is Rudaina Jaber, Brand Manager in Mondi Pharma. On behalf of every single one in our company, I would like to thank all of you for your valuable time to be with us, part of us. I was puzzled what to say tonight before the session of Dr. Talk Show, but I found two quotes that summarize all what you will watch tonight. The first one for Francis Picabia, saying that our heads are rounded, so our thought can change the direction. The second one for Socrates, saying that the secret of change is to focus all of your energy, not on fighting the old, but on building the new. Let's change the direction by understanding the superiorities of the new over the old in our rounded head. Join me to welcome our consultant, interlocutor, and advisor, Dr. Eslam El Baroudy. Dr. Eslam El Baroudy, he is a professor and consultant of pediatrics in Cairo University and Sheikh Khalifa Medical City.
Good evening, ladies and gentlemen, everywhere. Thank you, Rudaina, for the nice introduction. Thank you, Mondi Pharma, for the highly scientific and elegant gathering, as usual. It's my pleasure to be among all of you tonight, discussing something that living among us. But you will be amazed when I'm saying that, unfortunately, living with us. Why I'm saying that? Because a lot of question. So, how many times it is visiting us? How we are dealing with these members? Is it successful so far? Are we happy to leave them dealing with us that way? Do we have a new option? Obviously, I'm talking about the upper respiratory tract infections and symptoms, and particularly, I'm talking about sore throat. And despite of its popularity, but still, the proper understanding of scientific background for the diagnosis and the proper treatment is a kind of rarity. Join me to welcome our expert tonight, sharing their experiences, practices, and scientific background over years in pediatrics and adult field. Our experts tonight, Dr. Malcolm Borg, consultant and the chairperson of Adult and Pediatric Emergency Medicine Department at Sheikh Khalifa Medical City in Abu Dhabi, and Dr. Fahim Tadros, consultant otorhinolaryngologist, fellow of the Royal College of Surgeons in the UK. So welcome, my dear friends and colleagues. Ready for our hot topics and discussion tonight? Let's start. So, my first question, and actually it is for both of you, and it is, upper respiratory tract infection is the most common acute illness, not only in the UAE, but even worldwide. And it is responsible for most of the visits for the ambulatory care services in the ERs, in doctor offices. Can you elaborate more about that in different pediatric and adult communities?
Well, sure. Upper respiratory tract infections, as everybody knows, is a very common ailment. We've all had it as children, and particularly both children during winter and the seasonal variations, they are more exposed to such ailments such as rhinitis, pharyngitis, which is an inflammation of the pharynx and the throat, or even ear in children in particular. So there is a variety of manifestations of this disease, and its prevalence is higher in the winter and in the change of the season. It's also associated with a lot of effects. There are a lot of side effects that affect not only the patient but the family. And of all the adults that have been, the adults in some studies that have been examined, 23% of them say that they could not really do their job or do their task 100%. So there is a good evidence that there is the quality of life is seriously affected by upper respiratory tract infection, aside from its cost, but as in a recent study in Boston revealed that at least it costs the United States of America between $240 to $500 million a year.
So it's quite high. Malcolm, in your practice and from your own experience regarding the upper respiratory tract infection, the tonsillitis, pharyngitis, do you think antibiotic is really needed? This is maybe just like a question for all of our attendees also.
Again, from an emergency perspective and from an acute care physician perspective, the decision about where to start antibiotics or not is probably the biggest therapeutic challenge for treatment of specifically tonsillopharyngitis, so here we have to distinguish between all acute upper respiratory tract infections and specifically inflammation of the pharynx and the tonsils. So whereas a URTI, so nasopharyngitis with coryza and runny nose associated with cough, as well as pharyngitis is largely viral, a proportion of pharyngitis, tonsillitis may be bacterial. And that's where the diagnostic therapeutic challenge comes in for all physicians who deal with these cases in their practice. The proportions vary a lot, and so the proportions in age. So whereas older children and adults tend to have more, bacterial tonsillitis tends to be more common. Younger children and adults, it tends to be more viral.
Yeah, it's younger children is viral. There is a higher incidence of a viral disease amongst children than there is in above the age of 6, you would say, Malcolm? About that, 9. About 9. Yeah, well, you know, it's certainly preschool.
I think it is like more than 85%. Maybe it is a viral related infection. And just to make it simple, if you are quite sure that this is a bacterial infection, then at that time you are in need for an antibiotic. If it is not, and this is the case at the beginning, so you don't know this is bacterial, this is viral, this is fungal, even if just so. I mean, not to rush to the antibiotic. This is the point.
Which is quite crucial is most antibiotics in the context of pharyngitis are given for the prevention of rheumatic fever.
Yes.
It's a the primary indication is that, although it's often not discussed whether they actually limit the disease itself more.
The eradication of the cause, not to have the.
But when we say the importance, it's primarily with regards to the immune complications, which is acute rheumatic fever, rheumatic heart disease.
What's the situation of sore throat infection in adults, Dr. Fahim? Or just allow me to rephrase it, or just to have one word or one comment. Do you think that we need more effective, more comprehensive option to treat the root cause of this expected infection that coming to us in the offices?
Well, basically, in adults, as Dr. Malcolm said, the incidence of bacterial is slightly higher than it is in children. And the dilemma that the doctor or a physician faces at that time, am I really dealing with a bacterial here or a viral condition? Fungi are usually easy because you can look at the mouth and you can see the thrush, and it's an easier diagnosis.
That you cannot miss it.
Yes, but the trick is trying to identify. Again, one must keep in the back of his mind that viral is still a higher incidence than bacterial even in adults. So although the bacterial incidence in adults is higher than it is in children, yet the virus is still the predominant thing. And there are certain things that can hint to the doctor that he's dealing with a virus. For example, the most common thing is the rhinovirus, the cold. The sore throat is really never really that fragrant, and there is always associated nasal discharge. And you look at the throat and you don't see the white spots that you usually see with exudative pharyngeal, viral or bacterial. So a coryza is self-limiting in a short period of time. So that's one thing. When you come, for example, to the teenagers and the Epstein-Barr virus, it's called the kissing disease or glandular fever, you get a horrible tonsil and big lymph nodes, and you got maybe a liver or a spleen enlargement. Then that will tell you, the teenager, the kissing disease, the glandular fever, it's more likely towards a viral, so you aim at directing your investigations and your treatment towards that. Adenoviruses are usually associated with conjunctiva. Influenza has systemic manifestations with cough and diarrhea. So if it's any help, if you have systemic manifestations affecting an eye or a cough or a chest, it tends to be more toward a viral rather than a bacterial disease.
Just me here, I mean, would you rely on a scoring system? Something, I mean,
yes.
Just like to differentiate between viral and bacterial?
There are many scoring systems, particularly in pediatrics, and some of the criterion I mentioned here are involved in this assessment. So basically, if they give them different scores, the fever is a score above certain level, the lymph nodes involvements, other involvements in a cough, for example, and that will give you sort of modulate you into, or sort of ease you into being more confident in one diagnosis more than the other. So that is how we work. There are investigations as well, but
yeah. Would you put the allergy in your differential diagnosis between the bacterial and viral upper respiratory tract infection to have like any allergic rhinitis or something that it have confusing picture or no?
No, you do get granular pharyngitis with allergies, but they are tickly, and they are associated with a history of atopy, like the child or the adult might have had asthma or eczema or conjunctiva. So, and really it is either related to, it's a seasonal thing, or is it there all the time? And these are the tricks that you have to find. Is that something that is perennial all the year long? Could it be but basically allergic pharyngitis is not as common except in the itchiness as people would like it.
So, Malcolm, upper respiratory tract infection, whether it is viral or bacterial, still it is a dilemma. Can you give us just like an insights how you could differentiate in terms of investigation, the clinical pictures from your experience, long experience in the pediatrics?
So again, further to what Dr. Fahim mentioned, the first step would always be clinical. There are few causes of pharyngitis which have pathognomonic signs, but most of them have undifferentiated degrees of erythema of the throat, exudate, and none of the clinical signs are pathognomonic per se of either bacterial or viral. So whenever we suspect, we generally we test the throat. Most commonly we use a rapid antigen test, which is a swab and gives you a result within 10-15 minutes. And then again, the question is, what do I do with the result? These tests generally they range. They have to have higher specificity and lower sensitivity, and so when they are positive, they're generally positive. So if someone has a really angry-looking tonsil, or he has a scarlet fever type rash, they will. There's so much antigen that they become positive in seconds. If because the sensitivity is lower in the 70s, the range, a negative test does not absolutely exclude a bacterial cause for the pharyngitis, and so you may proceed to test the throat, particularly in the high risk group for rheumatic fever, where you really want to exclude it, like the children, older children and adolescents. But generally the trend has definitely been to test before you treat. So nowadays we never give antibiotics empirically for tonsillitis, because you would generally overprescribe antibiotics in about 50% of the time if you use just clinical features. And so we tend to do these tests to give us a greater measure of certainty that we are treating correctly. However, that still leaves a huge amount of patients for whom the only treatment, the viral pharyngitis, for whom the only treatment is symptomatic so far.
Thank you, Malcolm, and my friends, my colleagues, as we just heard from our experts tonight, still we are in the area of uncertainty. I mean, regarding the treatment, specifically maybe in the pediatric age group, is it viral or is it bacterial? Whether you have the test available at your facility to have like the rapid testing or not. So still that there is unmet need for the causal treatment of the pharyngitis, tonsillitis, or whatever is a sore throat. Do we have an option? Just stay with us and we will see what we will have tonight. Dr. Fahim, from your long experience, and if I'm a physician, just need to learn what are the items that I should include in my prescription treating the sore throat, knowing that more than 85% maybe it is related to viral infection. What I should include in my prescription?
All right. So we talked about the management, and we've taken our procedures, whether we do the rapid antigen tests and or even you can get the differential white blood count and send for a culture. The next step for you is to decide is that viral or bacterial, and it is most likely that you will encounter viral more than bacterial. So you are into supportive treatment here. You really want to advise this patient to hydrate, to have sedation, and to have bed rest. Everybody treated upper respiratory tract and pharyngitis. Grandmothers used to boil chicken and give them chicken soup, and chicken soup was wonderful, and it did treat millions of people.
Definitely, we were suffering of that
over the centuries. So basically, what we need to do is just assess the situation. If you decide in your mind that this is a viral thing, do supportive treatment. I find one of the most interesting and useful tool in my armatum is using topical mouthwashes that have a very good quality antimicrobial or antimicrobial effect. And of these, bovine iodine has been a star recently for many reasons.
So antimicrobial or antiseptic, or is it the same?
Basically, it is. What they mean by that, the antimicrobial is capable of killing not only cleaning the surface, but cleaning the bug.
That's a very crucial point.
And, and of of many of the products that are available, there are few that can claim with efficacy sort of being able to eradicate and kill viruses as well as bacteria as well as fungi. And for that reason, it's one of my favorites, and I use it quite frequently.
Malcolm, my friend, so just from your expertise and deep knowledge that I know that, so you have heard about the bovidone iodine as an antimicrobial agent, but how do you think it will help in sore throat treatment in pediatrics and in adults?
So again, further to what Dr. Fahim said, it's what you can offer when suspected viral pharyngitis is usually very little by way of treatment. However, when I was reviewing the literature related to the povidone iodine spray, I was quite surprised at how effective virucidal, bactericidal, fungicidal properties are of the molecule on the microbes in the oropharyngeal tract. So in terms of log 10 reduction, which is a logarithmic reduction of the amount of bacteria or viruses or microbes in the pharynx, it is significant in the range of 4 to 5 log 10 reduction, which eradicates 99.9% of the microbes in that area, and it does so in a few ways. Particularly interesting is the way it does so in viruses. And probably many will be wondering, can we therefore eradicate viruses from the throat using the spray?
Amazing, Dr. Malcolm, to know about the log reduction and how it is really important to understand it. But Dr. Fahim, could you elaborate more details about the mode of action of this povidone iodine?
Well, it's a combination of the two components of it. Povidone helps actually transmitting, or helps the transport of the iodine molecule into the microbial cell or viral envelope, or even if it's envelopeless. So basically it helps the transmission of the iodine into the microbial body, where it interferes with the process of protein synthesis, the DNA or the RNA, and that actually helps killing the cell, and in killing the microbial cell, and in killing the microbial cell, you are killing its negative morbidity on it, and it also decreases the load of the virus or the microbe or the bacteria or the fungi, and it's important to remember that this is a triple acting action, and in reducing the load, it also prevents the transmission of this agent or microbe from one cell to another, or from one organ to another, such as the bronchus or the gastrointestinal tract, etc.
And it is effective regardless, so it is for the viruses, for the bacteria.
And that's the beauty of it. It is not only virucidal, it's also antibacterial, and including the aerobes and the anaerobes, incidentally. So it's not only aerobe and the different kinds, the common sort of fungi, such as the Candida and the Aspergillus. So it has a very broad spectrum, and in doing that, we know it can kill these microorganisms and thus spread their damaging effect on the human body.
I know, Malcolm, that you are aware of some studies talking about this mode of action. If you could elaborate about it and how it is affecting the clinical picture, the improvement in the clinical picture.
So again, the studies that we reviewed are largely in vitro studies, where the virus, particularly because again, a lot of the interest myself as a physician is for viral infections, where so far our ability to target the causative action is very limited. So again, in these studies, the combination of the povidone iodine with the virus prevented its infection of the cells on the agar plate that were used obviously to replicate the scenario you would have in the throat. So again, this the assumption is that if you are able to reduce the viral load, then therefore you are more likely to have a milder infection that will hopefully be shorter in duration. Although this still has to be tested out in vivo studies. What has been so far tested in vivo is the reduction in so there was one study where a group of healthy subjects was used a gargle, povidone iodine gargle, and there was a marked reduction in absenteeism from school with viral infection, and so this potentially would be an application also for not just the sick person, but also at-risk members of the same household, particularly children, as a prophylactic measure.
So my understanding now that the povidone iodine, that it is acting on these, regardless, it is viral, bacterial, on the surfaces that in the pharynx, in the larynx, or whatever. So this is decreasing the viral load, and at the same time it is preventing the spread to any other cells or like any biological cells. So this would decrease the severity, and maybe it is having an impact on the duration, maybe itself.
And infectivity as well. So, to pass an illness onto someone else, you need to, the virus needs to be present in the secretion of the nasopharyngeal tract. So obviously,
so this is decreasing the load, even like for you in the ER, the ER visits.
Yeah, I think there is another component of it as well, is the host system, because most viruses really depend entirely on the host defense systems. Now, if your host defense system, which is your army, is dealing with 10 soldiers, it's not like dealing with 1,000 soldiers.
Sure, yes.
So,
good analogy, by the way.
So basically, if you are reducing the burden on your army, then the army is good. And pragmatically, as a virucidal, and as a physician, to protect myself and my staff, I usually do gargle with it, because I know I'm going to be exposed to it, but at least I reduce the chances of having a mega load and that my army gets overwhelmed and I fall sick.
So my understanding also that if, and correct me if I'm wrong, if one of the family member has got infected, then maybe the other family member, because all of us, we got scared, that we can use the povidone iodine as per this study?
I mean, it would make logical sense based upon the one study that's out there, that if both the sick patient uses it, then the assumption is that his ability to transmit the infection is significantly reduced. And also any transmitted infection in those who, for example, gargle with the povidone iodine may further reduce their chances by preventing viral particles that attach initially to the nasopharyngeal tract from invading the mucous membrane. So if you ask me, would I use it? I tell you yes.
Yeah, perfect. I mean, for me, it would be a really add-on to help the family members. I mean, guarding against like any spreading of the infection. Just for better understanding, let us together watch this video regarding the mode of action of the povidone iodine.
Povidone iodine, the active ingredient in betadine, is a molecule composed of povidone and iodine. The povidone carries the iodine to the specific binding site of the pathogen. A fraction of the iodine will be released as free iodine. These free iodine are delivered directly to the cell wall or membrane of the pathogen. They rapidly penetrate into the pathogen, causing pore formation and generate solid liquid interfaces at the lipid membrane, targeting the key groups of proteins, nucleotides, and fatty acids in the cytoplasm or membrane. The free iodine also reacts with the genetic materials, causing coagulation and irreversible deactivation of respiratory chain enzymes. Cytosol materials are lost through the perforated cell wall or membrane, and the key building blocks for cell survival are inactivated, resulting in cell death. The host cell-mediated immunity system, such as macrophages, is activated and engulfs the weakened pathogen.
Actually, it was a finger pointing, the mode of action of this povidone iodine. But it seems that povidone iodine is not only having a finger, but also it having a unique tool, which is the tolerability, the onset of action, and the efficacy. So I need to hear from you both regarding these two nomenclature.
Again, for pediatric practice, tolerability is very important. I mean, young children cannot gargle, so the introduction of a spray for an over 6 cohort is
very important. I was asking myself how we could, solve something like that.
No, I mean, children cannot use gargles at all. So for children, it's going to the delivery of the molecule and also the taste is going to be of absolute importance, because you can't you can try it with a child once, but they will not let you in subsequent time. So so this is very important. And again, the in vitro studies show an incredibly rapid onset of action of the molecule against the
just for the tolerability. That is it something related to a taste or something, or nothing?
To taste, obviously, and the side effect profile, which is insignificant. So again, both of these count when it comes to children. But if you can't get it into the child, you don't even have to think about the side effect.
Sure. Maybe this is something that Dr. Fahim can tell us about it. That's supposed to be with a specific taste. Maybe that there is.
Well, certainly, children, and particularly as Dr. Malcolm have referred to, are very sort of sensitive about what goes into their mouth, and they can very radically attack you or run away from you if you give them something that is bitter or that's unacceptable. So I understand that the new compound has a better tasting. It's mentholated, I believe, and as such, it would be more tolerable to children and to adults. Everybody likes a good taste. So basically, I think that's a plus. There's no doubt about it. The onset, as Malcolm was just saying, there are some studies in different places, but it is between 15 to 30 seconds is been reported in some cases. Seconds, yes. So you just before you finish Happy Birthday tune, okay, and but in order to be academically correct, it is certainly less than one minute.
Okay.
Certainly less than 1 minute.
Efficacy?
Well, it boils down to the log reduction, the efficacy. So 99.9%, killing power is significant. But what's most significant will ultimately be how that results in improved outcomes for patients and their relatives. So we hope to be able to study it further. Its in vivo applications, both as a preventer and as therapeutic agent over in the coming time.
As we are eagerly waiting for povidone iodine to use in the children and to treat the root cause, as we just said, of the throat infection, finally we got it in the UAE with a friendly dosage form for our children, which is the spray. So, Malcolm, how do you see that this new form of betadine as a throat spray is an adding value to your daily practice?
Again, as we were discussing earlier with Dr. Fahim, the assumption is that if children come in the early stages of viral pharyngitis, or any pharyngitis for that matter, even bacterial, even if they go with bacteria, with an antibiotic, it does not preclude them from applying the antimicrobial to the surface as well. The assumption, though, empirically, is that if they are early on in the phase of the illness, then by eliminating the viral flora from the or the microbial flora from the pharyngeal surface, less will enter.
I think this is really a very crucial point. Yeah.
Therefore, the host may be in a better situation to fight it and therefore have a shorter, milder illness. This is the assumption that one would make given the evidence so far.
Thank you so much, Dr. Fahim and Dr. Malcolm. It was really a fruitful and a great discussion today. And I hope all of us, all our attendees that have benefited from that it would affect our practice and enrich our practice. This is enhancing our treatment and our dealing with our patients. Thank you so much.
Thank you.
Thank you. So finally now, from our experts, we could recap many things that we have learned tonight. So first of all, we are talking about a broad spectrum antimicrobial. It is antiviral, it is antibacterial, even that we could say that it is an antifungal, working on the surface and preventing the spread of the infection. We are talking, don't forget, the two nomenclature. It is the tolerability, which is maybe for the adult one, it is the mental flavor, and even like the new package form, the spray one, that you can use it on the run, and even for the mom, it is much more easier to use it for the children. The other thing is the onset of action, which is actually between 15 to 30 seconds, maximum of 1 minute, and maybe like the longer duration. This would really help us in decreasing the severity and decreasing the duration and the spread of the infection. Effectiveness, that our expert were talking about it for tonight, that reducing the log infection, and just what I need to tell you that it was certainly and clearly the choice of our experts in pediatric and in adult fields. What about you? It is your turn to go the same as they are doing. So share with us your questions and the queries in the Q&A option, and we will be happy to answer it for you. This was Dr. Eslam El Baroudy, Professor and Consultant of Pediatrics, Cairo University, and Sheikh Khalifa Medical City. I was very happy to be among all of you, and hopefully seeing you soon again. Thank you.